Hello everyone, this is Karen O'Hara, Director of Marketing and Communications with WorkCare. Thank you for joining us for the fourth in our series on preventing and managing COVID-19 in the workplace. It's hard to believe we're in our fourth week. We appreciate your participation in this ongoing series that we're presenting with Dr. Anthony Harris. This session is being recorded and will be available within 24 hours on our YouTube channel. You are on mute and you may submit questions using the Q&A function on Zoom. At the conclusion of the webinar, we'll summarize your questions and answers and distribute a summary along with the recording. That'll be available on our website at www.workcare.com. I just wanted to let you know that we have a special webinar that we've scheduled for Friday at 9 a.m. Pacific, noon Eastern, on COVID-19 response, protecting employee mental health during a crisis. The speaker for that webinar will be our Associate Medical Director, Dr. Brittany Bussey. You should have received a constant contact invitation to that webinar this morning, but if not, please send a note to info@workcare.com and we'll make sure you get it. We'll be redistributing that invitation to later tonight or tomorrow. Our speaker today is Anthony Harris, M.D., M.B.A., M.P.H. Dr. Harris is a board-certified occupational medicine physician. He's our Vice President of Onsite Clinical Operations and an Associate Medical Director. He's been acting as our lead clinician for our COVID-19 response. And this is the fourth time he's been kind enough to find the time to bring us up to date on the latest developments. Now I'll turn it over to him. Dr. Harris, thank you.
Thank you, Karen, and thanks everyone for joining us again today. It really, truly is a pleasure to be able to speak with you week by week, give you updates, and have dialogue and questions afterwards. So we'll keep the inquiries coming, and we'll keep the answers flowing. So without further ado, we'll jump into today's presentation, which is going to focus in on some additional clinical evidence that's presented from the clinical presentation and testing. We'll go over some daily screening approaches to help protect workers, keep them healthy and at work, and keep those who are ill at home. And then we'll talk about more of the return to work philosophy and approach that we've seen clients use and has been working well. We'll touch briefly on a couple do's and don'ts from a practical standpoint as well. So when we talk about our format for today, those of you who are joining us for a repeat session, you'll see the format has not changed. If it ain't broke, don't fix it, right? And so that's what we're going to continue to do in terms of talking about clinical updates, the pathology, microbiology, going into the epidemiology, and then on to prevention and really focusing on workforce strategies as well. So when we talk about the clinical update, nothing's changed since last week in terms of the clinical horizon that we're seeing. In regards to presentations, it's still burgeoning to see more GI symptoms, up to 18%, only GI symptoms without other upper respiratory symptoms. The presentation of, as we mentioned last week, the loss of sense of taste, the loss of sense of smell has been demonstrated in some early peer review literature because of the infectiousness of the virus in the nasal epithelium, not necessarily the olfactory nerves. But nonetheless, we know that this is now a possible leading indicator of early disease, if you would. And when I mean leading indicator, that means you don't have the shortness of breath necessarily and the other constellation of symptoms. And so that is still persisting this week. When we talk about the incidence in the US, nothing's changed in that particular picture. It's gotten worse, obviously, but the widespread illness self-reported by the local, state, and community health departments is pretty much the same picture you've seen last week. Not rosy, right? And their hotspots continue to be increasing hotspots. But what we want to focus in on in terms of clinical impact now is explaining a little bit more about why individuals who may not be classically in that age range of susceptibility, the older individuals, 70 or older, 65 or older, why we're seeing some of those individuals, even the youngest as newborns, right, suffer and succumb to COVID-19. It has to do with the response from the infection itself. The first phase, if you would, and this is data from clinical literature from the Journal of Heart and Lung Transplantation, published recently in March, and they talk about two phases in general, right? And in regards to course of time and severity of illness, when you first are infected with COVID-19, there's a viral response, meaning that the virus is setting up shop in your body. It starts to multiply, and that causes your body to begin to respond in a way that unfortunately causes a decrease or almost a suppression in your immune system. And so clinicians are able to see that on laboratory tests like a blood draw that looks at your white blood cells. They can see a decrease in actual white blood cells that happens early in the phase. And we know that dampening of the immune response may promote or allow the virus to multiply rapidly and build up in the body, in the human system. That's when you experience clinically, though, the fever, general malaise, all the symptoms that we talk about, dry cough, not necessarily the shortness of breath or anything yet. It's not until you get into that second phase of the illness that you start to have those pulmonary effects. We won't go into the cellular components of why that happens. It's all about how the virus attaches itself to the particular cells in the lungs. And then if you want to know, the receptor is called ACE2. It's the same receptor that we saw with SARS back in 2003. But the virus attaches itself in the lungs because of how most likely it's dosed, how we're exposed to it with respiratory droplets, and there it sets up shop. Once it does, you start to have this onset of your immune system responding to try to clear the virus, but that response is inflammatory in nature. That's what causes the changes in the lungs to produce that shortness of breath. And as it progresses, the decrease in your ability to capture oxygen or breathe in oxygen and utilize it. And as the stage 3 starts to happen, this is why the young can be severely affected because their immune system innately is, for whatever reason, predisposed to having this dramatic inflammatory response. And we're seeing something called a cytokine rapid response, where the entire systemic body, if you would, has this gigantic inflammatory response, and that can be quite worrisome from a survivability standpoint, right? And so it's this cascade that happens even in the young. Again, not nearly as prevalent as we see in older individuals, but it can still affect the young in this way through this process. So as we look at the microbiology of the illness, and what we talked about last week was some of the early serological tests coming out. Serological tests meaning instead of swabbing my mouth, swabbing the nose, looking at the sample for actual genetic material with that laboratory analysis. That's the PCR test that you're probably familiar with, that has been around for about a month or so in high demand. But now we're having an increase in the number of tests that you prick your finger, you get a drop of blood, and we can look at look for those immune components from your body's response to the virus, particularly IgG and IgM, and that's what we're leveraging now more prevalently, which is becoming more prevalent to be used to understand who may be exposed acutely, meaning you're ill right now, or exposed in the past, meaning you've had the illness even asymptomatically, and now you've recovered and your body's immune, right? And so these tests in particular are leveraging that approach to even that immunity that your body builds up to even treat others. And I had this briefly in the talk last week, but didn't really explain it in tremendous detail. But what providers are doing and have been doing, even Mayo Clinic, we've been using serum from those who have recovered from SARS-CoV-2, COVID-19 overseas primarily, and we're using their immune cells, their plasma, to actually help us defeat the virus in critically ill patients in the hospital. Now, we've been doing this because China, again, showed early positive responses and effects from this treatment. Unfortunately, so far in the US, we haven't seen this show the beneficial effects that our counterparts overseas have shown. But those continue to move forward. If we look at specifically the tests that look at the immune system, there are a number of them on the market, ex-US, that have been around for a month or two. And these tests measure those immune components, the IgG and the IgM, and it looks for, are they present in your body? And the IgM shows up anywhere from 5 to 7 days, typically after you've been infected with SARS-CoV-2. And that presence of IgM is the first, and then IgG is another immune component that shows up as well. And that's what this test looks for, both IgG and IgM. And these tests are generally all the same. And the efficaciousness of them can be as high as having a sensitivity of 88% and a specificity well over 90%. And if we look at what's present and available in the US, the FDA, as of April 1st, cleared CELEX, which is one of the first rapid tests to look for IgG and IgM. And we'll show that later, but there's a link that you can go to and see the entire list of all 30 approved tests by the FDA under the emergency response authorization. So when we talk about leveraging these tests, we're doing so obviously to bend the curve with regard to exposures and increased disease burden. And if we look at disease burden per million people week over week, and I'm showing you this because it's that classic trend that you would typically see in a movie, right? The movie Outbreak, where you're seeing more density of disease globally. And that's what we're seeing across the globe, shifting towards the right, meaning higher incidence per million of people. And we're continuing to see that trend. Asia's being more affected. US is darkening. Parts of Europe are darkening as well in terms of burden of disease. When we talk about burden on a daily basis, we're seeing the same trend. Where the deeper purple means that there's more disease present on a daily basis, confirmed new cases of COVID, and now we're seeing the Asian, Russia affected in a similar way, right? And so as we continue to look at the numbers, total confirmed cases, the US, we're number one, right? We knew we were gonna be number one weeks ago with the trajectory that we're on. We're clearly there above Italy, China, and we're above Spain as well in terms of total confirmed cases this week, right? So this was last week, right under 200,000 cases. This week, we're just under 400,000 cases. So we're almost double that of our nearest counterpart. If we look at total confirmed deaths, however, we are not number one. Italy is still number one. United States is there after Spain. This was last week. If we look at this week, it's Italy, Spain, then the US in terms of total confirmed deaths from COVID-19. One of the things we want to look at new this week is total tests, right? We've kind of seen a different variety of charts trying to understand how are we testing, how are we doing in the United States compared to other countries. It's clear now that we are number one in terms of the most tests being performed, right? So that's the absolute total of tests that are being performed in a particular country. We're number one. But if we look at it from the perspective of number of tests per 1,000 people, we're not number one. We're number three, behind South Korea and Italy. Okay, so we still have ground to make up in terms of being on par with our counterparts, and we're on that curve to do more tests as we have more tests available, more variety of tests available. Again, 30 approved under the emergency utilization or emergency use authorization that has been promulgated by HHS. If we look at daily new confirmed cases or confirmed deaths, this is an interesting trajectory to look at in regards to have we started to hit a crest, right? Have we peaked, if you would, and started to decrease in terms of the number of deaths. There's some early data to suggest that may be the case. And this is data as recent as yesterday, showing that not just in the US, but Spain, Italy, and the United Kingdom, their trend downward in terms of new confirmed deaths on a daily basis has been trending down longer than we have. But hopefully over the next couple of days, weeks, we'll see this continued trend downward. If we look at then new confirmed cases from a doubling time, last week was the first time we took a look at this particular metric. Looking at it again this week, so this is last week, this is this week. So you can see a slight bend from last week, right? A slight flattening of the curve from last week. We were just about every 2.5 days doubling. That's decreased slightly to about every 3 days doubling, right? So we're trending in the right direction. Obviously, we're still climbing in numbers dramatically, but we're going to watch to see are we at the point where we've crested, but we're not quite there yet. So in terms of total confirmed deaths, we want to look at this metric as of today. We're doubling the amount of deaths, the number of deaths every 3 days roughly in the US, just under every 3 days. So we'll continue to watch this curve as we have these series prospectively. If we look at how the world data, and early on when we looked at world data and compared it to China, and the world data at that point about 2.5 weeks ago, 3 weeks ago, mirrored the data coming out of China in terms of number of cases. Now it's mirroring the United States. And so obviously the trend, as we trend downward, the world data will hopefully trend downward because we're all experiencing a decrease in the number of cases. Obviously the decrease in the number of deaths is what we're going to watch very poignantly. If we look at daily new cases, same picture, we're seeing a downward trend beginning with the number of new daily confirmed cases. This particular metric is looking at a rolling 3-day average, right? So we'll continue to watch this to confirm, hey, we're doing pretty good in terms of trending in the right direction at this point. This is an interesting map to look at because we want to see and get a picture of how are we prepared to handle the burden in the US and globally particularly, right? So this particular metric looks at how many doctors, how many clinicians do we have per 1,000 people in a particular country. This data is lagging data from 2016 from the World Bank, but it's the best we have so far. And if you look at the United States, we're between 2 and 3 physicians per 1,000 people. If you look at other countries that have been hit hard, they're actually a little bit higher than us. If you look at Italy in particular, 4 to 5 physicians in that range, 3 to 4 to 4 to 5 per 1,000 individuals. So it kind of begs the question, well, why are they experiencing more in sense of in the metric of mortality, right? And we'll take a look and dive into that a little bit more right now. But if we look at capacity of the healthcare, try to frame the capacity of the healthcare system in a particular country, this metric is helpful. It looks at the number of hospital beds. Now, it doesn't point specifically to critical care beds, meaning how many respirators we have or how many ventilators we have if you're in the US versus Europe, but it gives us at least some insight as to our capacity. And if you look at the US, there's about 1 to 3 beds per 1,000 people in the US. Again, those harder hit countries are higher on the spectrum. They have 5 to 6 in Italy, and we again can now postulate then there may be another cause for why they're seeing increased mortality in those countries versus their capacity to treat. And we haven't seen a difference in the proportionality of impact of this illness, right? It's still very much so 70 and older, 65 and older versus the younger population. But if we look at the hardest hit countries, again, in terms of mortality, look at Italy, right? They have the highest proportion of 70 and older in that region. And again, it mirrors the susceptibility to severe illness that we're seeing for age-wise. And so this can be, again, a strong indication of why that phenomenon is there. So let's start to talk about some of the prevention and some of the approaches. We're going to talk. I'm going to hit this every week almost until we see the picture start to change. But just to reinforce, the study that Stanford did, looking at how we bend the curve, looking at strong social distancing. Again, the picture hasn't changed. We need the strong social distance as the primary means of prevention of spread, right? But as we talk about other approaches in terms of workforce strategy, we want to talk about how do we get on the front lines with regard to understanding who's at risk, who's not at risk, who needs to be kept at home, and who is safe to go to work, right? And so screening and testing is critical to that. We know that screening is being done more broadly using infrared thermography. We've been talking about that for a little bit, and we do believe that is a yes in terms of recommendation. It's necessary, but it's not sufficient. And we'll talk more about why that is. But we also have been doing daily screening for individuals. But it starts with daily screening and it goes down the cascade of care to risk stratification. So what's your true risk of having COVID or not? And should that predicate that you stay home, or can you go to work? And then triage and diagnosis, case management is now that you've been properly triaged perhaps into the high and medium risk categories, are you in a position that you're quarantined for 14 days, and do you have the right care? Do you have the right treatment? And that is an approach that plays well into understanding when is the right time for the return to work, and what criteria play into the return to work we'll cover also in a couple minutes here. So if we look at the actual approach for screening and what it captures, right now infrared thermography captures the temperature. If we dig into the accuracy or the correlation between if I take a thermometer pointed at my brow or my temple, what's the likelihood it's going to actually correlate to my core body temperature? Evidence shows us that that correlation is about 0.44, meaning that yes, it's a positive correlation to core temperature, but it's not high. And so that means there will be a number of people that have a fever that we don't detect with a IR thermography or through IR thermography, right? And so from that alone means that we need to do more. Now let's compound on that the fact that if I present with a cough and no fever, chest tightness, shortness of breath, GI symptoms, no fever, headache, no sense of taste or smell, and no fever, again, doing IR thermography necessary, but not sufficient. That's why we want to make sure we're doing some type of daily screen. And we've gotten ahead of the curve in providing this, and a lot of partners of ours and large employers have started doing this as well, because we know we want to catch these other symptom presentations, right? And we're doing so to the order of several 100,000, in a matter of a week or two. And what we're seeing play out in the municipalities is that certain jurisdictions are requiring by law employers to do screening, daily screening for 100% of their workforce. So obviously that could be a burden to HR and to EHS teams. And we want to make sure we're providing tools to help with that. And we talked a little bit about that last week. We won't touch on it very much this week, but reach out if you have questions about it. But if we now talk about the, skipping down again, we won't hit risk stratification, triage, and management. That will be a topic for another presentation. But let's talk more about return to work, right? And let's touch on it more so than we did last week, because there are criteria that continue to evolve with the approach to return to work. And if we look at what has been used popularly in the US, it came from CDC publications that suggested if you meet this criteria, you're able to return to work. But this protocol being 3 days without a fever, not using any kind of fever suppressants, and having been 7 days since the presentation of your first symptoms, then you're in a position to return to work, right? And appropriately, perhaps, we've had a large delegation of employers that took this and have run with it. But unfortunately, CDC recommended this specifically for the healthcare community, right? And it was in an attempt, we believe, to make sure that we're not being over prescriptive in regards to getting people back on the front lines in the healthcare industry, but also being protective enough to prevent spread of disease. They also continue you that sick employees for non-healthcare related scenarios should follow recommendations of CDC, discontinuing home isolation, but also in consultation with their healthcare provider, state and local health departments, right? And so there's a clear role because of nuances in regards to that return to work approach that we need to be considering when we talk about how do we get safely people back to work. So what are those different nuances? Again, CDC says, hey, for those nuances, please follow the guidance of your healthcare provider right after they lay out the criteria for discontinuing home isolation, which again was their recommendation here. Follow the recommendations of CDC for discontinuing home isolation. So if we look at that criteria, it's the same basically as the healthcare worker, right? The 72 hours without symptoms of fever, improving symptoms, and 7 days have passed. But that's if you won't have a test, right? If you're going to be tested, they want you to have 2 negative tests for COVID-19. Why is that? We talked about it briefly before. A negative test doesn't mean you don't have COVID. 30% of people with COVID will have a negative test using classic PCR, right? 2 tests will decrease that to only 9%. 3 tests will decrease that to 3%. So CDC clearly says if you're going to be tested as negative, have 2 tests at least. That approach is something that is sound in regards to return to work scenario, in that we want to assure workers that when I come back to work, I'm in a safe environment, hopefully free from disease, and my coworkers have all undergone the same process to evaluate, are they a risk for transmitting COVID-19? Right. And so with that approach, we have seen more and more tests offered at the workplace so that before you re-enter, you could have a negative test at the point of care. There's a provider in New York City with 3 locations that has set up basically a trailer with employers, and they are able to do rapid testing on site for the re-entering workforce. And obviously, that's something that is mirrored with what we're doing at WorkCare, but it's an approach that takes a holistic look at, hey, there's 2 scenarios that we're able to address, right? That we're doing the right thing for testing and re-entering, and we're also taking into consideration those factors that are nuanced for each in particular case, but we're also providing a means to decrease anxiety for the workforce, knowing that the workforce is undergoing the same process across the board. We believe that's best practice. So as we dig into those criteria a little bit more into the mind of the clinician that we have to use when we have a case-by-case return to work, we talk about exposure, right? We get a true, accurate history of, hey, was your exposure, somebody in the community that you spent 6 minutes with and they were later confirmed for COVID-19, or was it somebody in your household you spent 6 days with, right? That was confirmed for COVID-19, and what was that duration of exposure? The disease component of it is, did you become symptomatic for COVID-19? And if you did, what was the onset, durations, and severity? Because all those play a role into, are you still or potentially infectious? We know that most people recover from COVID-19 in about 12 days when they have mild to moderate illness. You can have a period of infectiousness beyond that, and that has to be a consideration when we're talking about return to work. When we talk about the level of infectiousness of an individual, again, duration of leave, how long were you quarantined? What are your job duties? Are you returning to a situation where you have to work with others in close proximity because it's unavoidable due to the nature of the work? That increases risk, right? The ability to practice social distancing and availability of personal protective equipment, also considerations when we talk about return to work that should be at the forefront before a thumbs up, if you would, is given for a return to work scenario on an individual basis. And then there's other things such as orders and policies, right? Company policies and procedures that need to be considered and adhered to, basically to, again, give that broad brush approach to helping the workforce decrease overall anxiety with regard to, am I safe at the workplace or not? And some do's and don'ts from a practical standpoint, we've kind of seen it all at this point in regards to protocols and processes and procedures. If we look at what CDC is recommending now, should I wear a cloth face mask or not, right? And what's the significance of it? And it's clearly the cloth face masks that are suggested are not to protect you from exposure to particularly yourself as you're wearing the mask to protect you from exposure to COVID-19. It's mainly that if you are a carrier, meaning asymptomatic, and you can transmit COVID-19, you want to protect others around you. And likewise, when others are wearing their cloth mask, they're helping protect you, right, from that potential exposure. So we say, yes, that is a recommendation for the workplace as well. We do work with employers that have laid this out across the board, that you should wear a cloth mask and or some type of dust mask at a minimum when you're in the workplace. Now, in terms of don'ts, right, we have employers that kind of go overboard, and they've recommended in some cases half face masks, full face masks. We haven't seen too many of the full, hooded rebreathers, right? Self-contained air purifying respirators. But again, the recommendation should be provide something to workers that, one, have that unavoidable proximity to others, or two, have a increased level of anxiety, or from a practical clinical standpoint, have some type of pre-existing condition that may predispose them, right? So you want to have these things available in the workplace. Should you require them? We have employers that are doing that, but it's based all on the notion that it takes the community to protect those who may be vulnerable and at risk. And that approach of wearing these particular masks, dust masks or cloth masks, help achieve that. So I'll stop there. I know we covered a lot quickly as we normally do, but I want to give a chance for questions here, and we'll jump into it. Thank you.
Thanks, Dr. Harris. This is Karen again. We'll start in kind of chronological order. The first few questions relate to the world map and case rates. One participant wants to know if there's anyone tracking people who are calling their doctor because they're sick, but they never receive a test because of the shortage of tests.
Perhaps a significant problem. Anecdotally, yes, it's been a problem for large providers, even as ourselves, to access to tests. But as far as data being tracked, I have not seen that data in particular being tracked from any particular body. Okay.
And in regard to the 3 stages of symptoms that you showed, is the person more contagious or less contagious at any one of those 3 stages?
So we know that individuals before they are symptomatic are potentially less contagious. And when you're symptomatic, you are actually carrying a higher burden of the virus in your body. And so every time you cough, sneeze, etc., create droplets, there's more virus in each droplet, and that's when you're symptomatic. So the peak is then less when you're pre-symptomatic or asymptomatic, but still able to transmit the disease at any given point.
Okay, and in regard to measuring the presence of the virus in the environment, can you use an RNA test or something else if you can't use a test that's for bacteria for a virus? So how are they detecting it in the environment?
So they're not detecting the virus necessarily in the environment outside of testing with a protocol to look at specific endpoints, right? So if I'm doing a study and I'm trying to see, as studies have been done, how long the virus can survive on different surfaces, then I can use the same process of PCR to look for that genetic material on those surfaces or in the air in the environment. That is not a routine test that's being performed across the board. That's usually predicated towards a particular line of investigation. So there's no test available that I'm aware of that allows you to, let's say, pick up a kit and go test your house, right, for virus present there or not, or your workplace present there or not. But it's more on the research end.
Okay, and the same person has a question about containment in some countries, for example, India and Mexico, where they might not have as high a standard as compared to other countries for protection. What is the risk of cases continuing to grow, the case rate continuing to grow there and infecting others and continuing the pandemic?
Sure. I mean, I think that question is getting at I guess, two things: local disease, right? What's the burden of local disease opportunity? If there are no precautions taken, right, with regard to social distancing or even wearing masks and available materials to help prevent, then the classic curve that we would see, S curve, for pandemic incidents would likely continue to grow, right? And the risk then on the second part of that to other countries that may have some trending downward of illness may be vulnerable if we stop basically the travel in between those areas that may be high endemically with disease, highly burdened with disease, versus those lower. So the opportunities there, if we ease the transmission from one location to another. And that's what it's all about in terms of a global coordinated effort to eradicate or decrease the pandemic incidence.
Okay. This question is about the use of nasal swabs for instant testing. In this case, the employer has a local hospital network conducting screening using the nasal swab quick response test. They have first responders who need to go to emergencies and highly critical functions to control room operations, which are highly trained, but there's a limited pool of employees. Do you recommend that they take this proactive approach, and what do you know about false positives and false negatives with this test?
Without knowing the specific test you're referring to in regards to, that test protocol, we can.
They're referring to the Abbott test specifically.
Got it. Okay, and that's what I was going to gather, that most likely they're referring to the Abbott test, which was approved within the last week for rapidly testing at the point of care or on site the presence of genetic material, and it's still the classic approach that we've seen with other testing. I don't know the specific sensitivity and specificity of that Abbott test, but in general, again, the PCR test is showing a false negative rate of 30%. Again, meaning that 30% of the people with coronavirus will get a negative test from that approach. Hopefully that will improve over time, but as far as I know, I haven't seen any data to suggest otherwise with that PCR approach.
Okay, and for the test that for return to work, what is the gap between the first test and the second test? What's the recommended time period for retest?
24 hours is the recommendation between each test.
Okay, and then after an exposure, can a person return to work if he or she meets CDC parameters prior to the 14-day period after an identified exposure?
Say that one more time here, just to make sure I'm understanding correctly, please.
After an exposure, can a person return to work if he or she meets CDC parameters, 3 days, 7 days, negative test, prior to the 14-day period after an identified exposure?
The answer is yes, in conjunction with a individualized approach with your provider, and that's the CDC recommendation. We do stand behind that best practice because there are those nuances in each individual case that need to be considered.
Okay, and this question is about exposure risk. What do you suggest if an employee gets sick, stays home, and calls his supervisor, but he's not tested because of the shortage of tests? What's the likelihood the rest of the employees may be infected? Should they be quarantined as a precaution, self-quarantined?
Again, the individual case needs to be further clarified. So what the process for that is an interview of the individual by typically a clinician and a series of questions to ascertain what their true risk of having COVID-19 is, and their current symptoms. Individuals can be diagnosed with something called presumptive COVID, meaning you've been evaluated by a clinician, you haven't had a laboratory test, but yet all your symptoms are consistent with that of COVID-19. And if a clinician diagnoses you with presumptive COVID-19, as this case would most likely require if no testing was available, then contact tracing would be the next step, as if the same process for a person confirmed with a test. And we've done that numerous times with employers in that very scenario.
Okay, and regarding the antibody test, do they indicate if a person is currently contagious or if they've gotten over the disease?
So both. So if you're positive for both IgG and IgM based on the rapid antibody test, then you can still be acutely ill and you can still transmit the disease with both of those being positive. You also can have a positive test if you've previously had the disease and have recovered. And again, that's case by case in regards to, are you symptomatic or are you not? Were you asymptomatic the entire time? But that can look at both acute and past illness.
Okay, there's quite a few more questions about testing, but we need to wrap up, so we'll have to address those in our follow-up Q&A, which everyone will receive by tomorrow. There's just a couple more kind of miscellaneous ones we can quickly cover. One of them is the question about why the African American population seems to be more affected by the virus compared to other racial or ethnic groups in the United States.
Sure. So there hasn't been any peer-reviewed articles that I've seen so far that do a retrospective or obviously not a prospective study to look at that particular question, because there will be multiple factors in regards to the impact to a particular demographic, right? Social distancing would play one part. There may be some type of genetic susceptibility as another part. We do know that African Americans, if we're talking about from a genetic molecular predisposition, have different receptors, in particular for this particular illness. The ACE2 receptor, we know, plays a critical role in antihypertensive treatment, right? High blood pressure. And we know African Americans, with regard to medications, have a different response as a result of that variability in the cascade of response to that, well, in relation to that ACE2 receptor. The ACE2 receptor is what I mentioned earlier that the virus attaches itself to, particularly in the lungs, right? And so there may be some predisposition there. We don't know. It is the final answer, though. It needs to be studied and it needs to be clarified. But the potential is there, and there are different things being theorized, but nothing conclusive to actually point to for any type of and so far I haven't seen any peer-reviewed publications that actually confirm the disproportionate effect on a particular demographic, other than age-based, for sure.
Okay, we have time for one last question. It's related to patient privacy and the Health Insurance Portability and Accountability Act, HIPAA. If you're doing testing on site around other employees, what kind of steps can you take to ensure that their private health information is protected? I know that HIPAA has a provision where in an emergency some of the regulations are relaxed, but perhaps you could address that and then we can wrap up this session.
Absolutely. So yes, that's true. EEOC, ADA, HHS has relaxed HIPAA for use of testing on site by employers, for even use of telemedicine with an iPhone or an Android phone versus some other type of software. But we still recommend best practices with regard to privacy. So if you can establish a workflow for an individual that's going to be tested on site in the presence of others, that somewhat limits that immediate environment to being able to hear or the discussion between the tester or the person being tested. At a minimum, obviously, you're going to do social distancing 6 feet apart, right? But setting up partitions, using geographic separation is a way to help mitigate any kind of HIPAA poor practice, if you would. So that would be our recommendation, is to still put things in place to try to limit the potential for those type of shared and missed opportunities to protect.
Thank you, Dr. Harris. I just wanted to express our appreciation to everyone who participates in our weekly webinar series. It's very informative. All your questions are really appreciated and shared with others so we can all learn from this experience and have the best possible solutions to protect and promote employee health. We look forward to you joining us again next week. And I wanted to remind you again about our mental health webinar on Friday. It will be recorded, so those of you who can't participate live, that recording will be available. And everyone be safe and sound. Dr. Harris, thanks again.
Thank you, everyone, and we'll see you next week. Take care.